Hi class, this is my reply to discussion board 1 for this week regarding the principles of pharmacokinetics, pharmacodynamics, and pharmacogenetics. I learned a lot through this week's module, but mainly I learned that we use a lot of these principles in our everyday practice without even knowing that that's the specific term for them. I want to focus on pharmacokinetics in my reply because this is what I'm going to use for the examples that I'm going to use. Pharmacokinetics is the movement of medication through the body from when it enters the body all the way to when it is excreted from the body. The study of pharmacokinetics allows nurses to understand and predict the actions and adverse effects of the medications that they're administering to their patients and how the drug actually reaches its target cells after crossing through all the barriers that it has to in the body. The process of pharmacokinetics is grouped into 4 different categories: absorption, distribution, metabolism, and excretion. I want to focus on the latter two, metabolism, and excretion for my example. So when a drug is metabolized, the body chemically changes the drug molecule into a form that is more easily excreted through the body. Usually medications are formed or manufactured in a lipid-soluble form and to be more easily absorbed and distributed through the body. But once it is metabolized, the body typically creates metabolites or end products that are in a water-soluble form so that the medication can easily be excreted through the kidneys. And then at that point it's less likely to go back into the body tissues. One example of a medication that I want to touch on that we give every day that most of our patients are prescribed to is Tylenol. Tylenol's metabolites or end products after metabolism have actually a greater or a higher toxicity than the original drug of Tylenol. Tylenol's metabolites are highly toxic to the liver. So this is important in our liver failure patients. Their liver is already damaged, so we do not want to give something like Tylenol that is going to destroy that more. It's good for nurses to understand this and be thinking this way because Tylenol comes on a lot of standard order sets, and MDs may just be checking boxes and not understanding that. And so understanding this type of pharmacokinetics can help nurses catch these errors. So a drug will continue to act on the body until it's either completely excreted from the body or metabolized into an ineffective form. Or inactive form, I should say. The rate at which a drug is excreted is determines the concentration in the blood and ultimately the duration of action of the drug. So liver and kidney diseases can greatly increase the duration and intensity of a drug's action in the body because the body's ability to metabolize and excrete the drug normally is completely altered. So we need to know our patients, what they're suffering from, and how this is going to affect our medication administration. The principle of pharmacokinetics has definitely guided all of our care for patients. I provide a great deal of care for renal patients in addition to liver failure patients. I've had an incident where a narcotic was administered to an end-stage renal patient, and it did seem to just circulate, almost for a couple days, just one small dose, because her kidneys were not able to properly excrete the drug. So this was a narcotic that should not have been prescribed, but the doctor probably didn't think about the whole process of pharmacokinetics in her specific body. Therefore, the effects were not optimal for her. Another example of how I use pharmacokinetics in my practice is the fact that I administer drugs that require therapeutic drug monitoring, such as Vanco and digoxin. We all know that vancomycin is important to draw trough levels prior to the next administration of vancomycin. It's important for nurses to understand that the trough level needs to be drawn when the medication is at its lowest point in the body. This will help us dose the medication appropriately. So this is an example of how if the nurse didn't understand the whole pharmacokinetic aspect, she may accidentally administer the drug prior to the trough level being drawn. I've certainly done that in my early years of nursing, and so it's just another example of why it's important to understand these things. My specific clinical experience that I'm going to talk about, where I unknowingly used pharmacokinetics, was when I had a patient who came in who had an extensive history of PEs and DVTs. So this patient needed to have surgery on a necrotic toe wound. He needed to have it amputated. He came in on Coumadin and Plavix for other history, and they went ahead and DC'd his Coumadin 5 days prior to surgery and DC'd his Plavix and started him on sub-Q heparin shots, 5,000 units. First, I was using pharmacokinetics by simply administering the heparin subcutaneously. This has to do with the process of absorption, which explains how heparin reaches its target cells. So we know that by administering heparin subcutaneously, the blood cells in the skin tissue absorb it and eventually help it reach its target cells. So obviously sub-Q meds are absorbed more rapidly than PO4 medications, but not as rapidly as IV or inhalation. So to continue my example, this particular patient was going to have surgery in the morning, and the doctor wanted him to receive, anticoagulation up until the last point where it wasn't going to be safe anymore. So it was kind of a balancing act of how long should we anticoagulate him to where he doesn't form a DVT or PE, but when do we need to stop so that there is not a risk of bleeding in surgery. So in order to do this, we had to consider all the processes of pharmacokinetics. This is where metabolism and excretion principles of pharmacokinetics came into the picture. So liver is the primary site of excretion, but kidneys also play a role. I know, and we all knew in this patient's instance, that the half-life of heparin is short, and the peak levels are typically 2 to 4 hours, although that can vary by individual. The main site for metabolism of heparin is the liver. So because we knew that the average half-life is only about 1.5 hours and it's excreted through the urine, we used all of that information, or the doctor did, but it's also important for the nurse to understand it, to be a good double check and make sure she knows why she's administering drugs. But anyway, all of this information was used to determine that the patient could receive his PM dose of sub-Q heparin, and then we held the morning dose prior to surgery. So that's just a quick example of how pharmacokinetics played a role in making sure that this patient received optimal care. We knew that we had to hold the heparin at least 6 hours prior to surgery in order to make sure that he didn't have a risk of bleeding. So that's just an example. I'm sure most of us have probably had that same instance and didn't even realize what all aspects were playing a role. To move on, as far as pharmacogenetics, that's the study of how our genetic variations interface with disease, risk, and our responses to certain drugs. This is something that I'm definitely interested in, but haven't really had a lot of experience with. I certainly haven't really seen a lot of genetic profiling in the hospital setting. I think it would be great. Maybe it's the future of healthcare, and I think it would be very beneficial, but I haven't really had a lot of exposure to it. In my patient's instance, having access to his genetic profile would definitely have helped us provide better care to him. This could have given us access to information about the activity and the function of enzymes in his body and how they react with heparin and, Coumadin and all the other medications that he was on. This also could have helped us understand why was he so prone to clot formation, why did he have so many DVTs, what factors were controllable and uncontrollable in his life. So pharmacokinetics could have provided this patient's treatment team with information about how his body would respond to the heparin injections as well. If we had his genetic profile, we would know exactly how long does it take for his body specifically to metabolize and excrete heparin. How, when is the drug being given at a therapeutic level in his body? Would he experience any adverse effects? So on and so forth. So it could definitely contribute to a more individualized plan of care. Other than that, just to touch on one fact that I found really interesting, according to our course content, genetics contribute to from 20 to 90% of how our bodies respond to drugs. I think that's really significant, especially if it's closer to 90%. The genetics can actually play that big of a role. So the idea of pharmacogenetics, genetic profiling is very, very important and should be considered, more often in patients' care plans. Other than that, I just think that all of these factors were interesting to learn about. As I said, I think we use them more than we know that we do, and I think pharmacogenetics can definitely be beneficial and help us to provide our patients with great patient care, and hopefully it will be used more widely in the hospitals in the future. I hope you guys have a great week, and thank you for listening to my discussion board. I'll talk to you soon.